All right, well, it is my great pleasure to introduce Louisa Vahedi, who is joining us from the Center for Global Health at what we in Toronto very affectionately call Sick Kids, the Hospital for Sick Children. Sort of disappointingly and frustratingly for we Canadians, Sick Kids is only ranked second best children's hospital in the world out of the 250 hospitals in the current rankings behind Boston Children's. So it's not just the Toronto Maple Leafs and the Boston Bruins, so we're very frustrated. Anyway, so Louisa is working currently as a biostatistician in that very esteemed place. She's a social epidemiologist, did her PhD at Washington University in St. Louis, and she is currently doing a postdoctoral fellowship at Sick Kids. She also did her master's, at Queen's University, where I did my postdoc, and we both actually had the same postdoc sponsor, the Social Science and Humanities Research Council of Canada. So it's my great pleasure to introduce Louisa Vahedi.
Good afternoon, everyone. Thank you so much for joining me here today. I'm really excited to share with you a bit of my work. You can see here a very dynamic and fun slide on syndemics, and I really see this as a new frontier in global health equity. So I'll begin my presentation by telling you a little bit more about myself. I'm new to many of you in the room, and I'll focus on my career trajectory and research. So I'm going to organize telling you about myself using this framework. I'll first start off by telling you what I do, the outermost layer, the training I have, the content area that I study, and some of the publications I'm especially proud of. But then I'm going to move in to tell you how I study my substantive area, the methods, the frameworks, and tools that I use and why I use them. But the innermost layer is why I engage in this work in the first place, the driving force behind this larger agenda. So let's get started, and I'll first start off by telling you about my academic training. So I'm actually Canadian, and I started my undergrad at Western University in London, Ontario, Canada. And it was at this time that I was interested early on in population health and well-being, but I didn't really know what that meant or how to articulate that. And through training at Western's Health Studies program, I learned about the physical, social, and political determinants of health through a lens of equity and social justice. And this is really what I'm rooted in. So to use this metaphor of a tree, I consider this the disciplinary journey that roots my scholarly activities. Now, it was during this time that I took my first Women and Gender Studies course, and I think that completely changed things for me because I realized what I was really passionate about was mixing together the social, physical, and political determinants of health as they relate to women's health, children's health, and gender minorities in low and middle income countries. So with that in mind, I asked myself, how am I going to grow now that I have this rooted foundation? And I pursued a Master of Science in Epidemiology at Queen's University in Kingston, which is close to Canada's capital of Ottawa. And it was during this time that I grounded myself in the quantitative epidemiological methods that are cornerstone to global health. But I realized that those methods were somewhat limited in understanding the content area that I was really interested in, which at that time was sexual exploitation and abuse perpetrated by United Nations peacekeepers in Haiti and the DRC. So how can we come up with a nationally representative sampling frame when maybe there isn't one in these types of settings? How can we measure a construct that is relatively less defined or less concrete, like sexual exploitation and abuse? What does it mean for the women and children that experience it? So here's a couple of examples of the publications that I've published in this area, and you'll notice they're qualitative. So I supplemented my quantitative epidemiology training with qualitative ways of knowing that has actually proven very beneficial in terms of my PhD, which I have recently completed at Washington University in St. Louis. So I took this time to really deepen my understanding of qualitative and quantitative methods, how they can speak to one another, how they can be complementary, and help us tell compelling stories about why our research matters to different audiences. And I also have been thinking about how to strategically combine them to investigate development issues in some of the world's most complex settings to mount a public health response, those so-called fragile or underdeveloped countries that some of our work is in global health. So I published conceptual papers, quantitative papers using nationally representative data, and some qualitative investigations as well. These days, I find myself thinking a bit more critically and conceptually as a postdoctoral scholar about what fragility means. In global health, we tend to use certain terms and constructs like failed and fragile settings without truly thinking about where they were developed, what implications they have for our practice, and how they've shaped our thinking in somewhat insidious ways. So I'm taking this time as a postdoctoral scholar to critique a bit of what we know and to reimagine these concepts in a way that might be more globally applicable, given that many of the global health threats that we are grappling with as a generation are transborder, climate change, disinformation, etc., and how all countries, regardless of their so-called development status, engage in a process of fragility related to governance structures that is maybe similar in ways that we couldn't see when we're talking about failed and fragile settings within the conflict arena. So, now you have a better grounding of sort of who I am as a scholar and how I've trained, but I want to explain a little bit more my positionality and how it's related to what we do in global health. So if you asked me, who are you, what do you do, I'd probably tell you I'm a social epidemiologist because I'm interested in how social and political structures become embodied. So how they become embodied in the way we think, act, behave, that eventually translates into disease, disability, mortality. And I use mixed methods research. I think qualitatively and I think quantitatively, and how to bring those two languages together. I'd like to also go beyond just explanation, associations that are causal, but to explain a phenomenon deeply and it's all of its contextual nuances. So how and why does a pathway occur and how can we intervene on it? And this is what I like to call explanation in causal thinking. But overall, I'm a violence scholar, so the issues that I grapple with using mixed methods tend to deal with violence against women and children, domestic violence, intimate partner violence, sexual abuse, and whatnot. The larger scope of what I aim to do is think about health disparities as being individually felt, but ultimately structurally defined. So how do we use our methods, our theories to get at the structures that lead to individual health disparities at a population level? So far I've told you what I do and how I do it, but I haven't told you why I'm even in this space to begin with. And I start off by telling you that I guess my training started at Western University, but that's not entirely true. My journey actually started with the story of immigration. So I was born in Eastern Europe, in one of Eastern Europe's most eastern regions, which is Romania. There's a little flag there for my hometown. And oftentimes I find people associate Romania with its 40-year communist history. And it's true, Romania did have a nearly 4-decade communist history. And here's a photo of the Palace of Parliament, which was built and constructed during that time. And it's actually the world's most expensive administrative building. And it's the second largest after the Pentagon. So there's a little fun fact for you. But across the Black Sea, where my hometown is the second part of my ethnic identity, which is Iran. And Iran also had a history of revolution in the 1970s, which brought forward the current regime. And with it, modern day images of Iran with revolution and protest, such as Women, Life, and Freedom, which I'm sure we are all familiar with. So eventually, along with my parents, we immigrated to Toronto, Canada, and that opened the door for me to train at the institutions that I have told you about. So I wanted to show them here on a map for those of us who aren't too, familiar. I certainly am not too navigationally oriented, but in purple is Western in London, Ontario, close to the Detroit border. I went up to the orange pin holder there to attend Queen's University in Kingston, about 2 hours away from Canada's capital of Ottawa. I then went down to St. Louis to do my PhD at WashU, and then I'm back up there in Toronto where the blue pin holder is. So that's been my journey, a journey of migration, and extending this imagery or this theme of migration is the journey that we are going to be on today. So here's the agenda of what I'm going to be taking you through. So I want to give a background and I think where we are in global health as a discipline as it relates to violence. I'm going to talk to you about the theory and conceptual model that grounds most of my work. It's syndemic theory, as you may have gleaned, and it's my favorite theory, so I'm happy to be here in this space sharing it with you. I'm going to talk about some selected research projects that I've worked on for the past 5 years, and future research plans, and ending with a question and answer period. So there have been many global health successes over the past 5 decades and counting, one of which is the reduction in child mortality, which has occurred somewhat consistently since the 1950s, albeit there are still some disparities between regions. So from this, we can glean that generally speaking, children are living longer. Yet there is persisting violence. So children face multiple forms of violence throughout their life course, including in adolescence and beyond, one of which is violence by caregivers and those in positions of authority. Another is intimate partner violence, especially when girls enter their first relationship or their marriage, which in many contexts happens during adolescence. And witnessing violence between their caregivers, so witnessing domestic violence or intimate partner violence. So violence sometimes marks the childhood experience and adolescent experience at sensitive periods of physical, emotional, and cognitive development with enduring consequences into adulthood. And many of the prominent violence scholars that are in this room and in this faculty will tell you that intimate partner violence and violence against children share many of the same drivers, some of which are listed here on the slide, and they range from micro level, so substance use, individual experiences of stress, household level poverty, to macro level drivers. Here we're talking about the lack of social protections, climate change, conflict, etc. But these drivers do not occur in isolation of one another. For example, it would be, I think, strange to talk about poverty and violence without also talking about stress, substance use, norms around masculinity. So on one hand, there is a recognition that these drivers intersect and cluster in particular ways, yet most of our science and understanding focuses on associations between one risk factor and the outcome of violence. So we need a new descriptor to explain what is going on. In 2023, the World Economic Forum came out with a very interesting report about the cascading and interconnected crises that the world finds itself in 2023. And they argue that to fully represent this complexity, we need to look at it through what they call a polycrisis lens. So here on the slide, we have the polycrisis in its entirety, or at least as explained by the World Economic Forum. And the polycrisis is said to occur when risks interact and they cluster such that the overall impact of these risks exceeds the sum of each apart. Now, if I were to explain this entire polycrisis, I'm afraid we'd be here until next year. But instead, what I'm focused on is really analyzing violence through a polycrisis lens. So this begs the question for us working in global health, which is how do we engage with this complexity? When there's multiple risk factors interacting with one another, we might have endogeneity problems. Where does one begin and where does one end? So in my work, the way that I've been doing this is to think syndemically. So has anyone here heard about syndemic theory? Yes. And has anyone here used or applied it in their work? Okay, so this is very exciting for me.
Show off.
Yeah. I kind of planted, I think, that question because I get to tell you about how I've been using this theory. So syndemic is a play on two words, synergy and epidemic, and it was coined in the 1990s by a medical anthropologist named Meryl Singer. And I might have a bias here, but I think the best theories come from anthropology. But he was conducting ethnographic field work in a Puerto Rican community in the United States. And he noticed that violence, substance abuse, and AIDS were inherently interconnected, and that you couldn't really study one without also studying the rest. So from those early beginnings and the original syndemic model, substance abuse, violence, AIDS, epidemiologists and global health scholars have been working to operationalize this theory. So we have the 2017 version up on the screen, which is published in the Lancet. So according to this model, a syndemic occurs when inequitable socio-political contexts perpetuate the clustering and interaction of diseases, epidemics, human rights violations. And given these interactions, whether they are biological, social, behavioral, what happens is that population harms are magnified above and beyond what would have happened if the epidemics occurred in isolation of one another. So this is a complex theory. It assumes many different postulates, but I can summarize them and distill them down into three: context, clustering, and interaction. So you may be wondering, what does violence have to do with it? Because I'm a gender-based violence scholar. Well, it was interesting for me to learn that gender-based violence has been central to syndemic theory since its first development. And Meryl Singer in his 1996 paper actually told us that violence wasn't a part of his initial design. But in conducting ethnographic field work, he noticed the frequency and painful impact that it had on the community, and that it was central to the prevention of HIV/AIDS and substance abuse. So this is really where my research is housed. It is mainly focused on understanding gender-based violence syndemics, bringing gender-based violence into the center of what syndemic theory has always been. I am motivated by understanding how these inequitable socio-political contexts are embodied as violence perpetration and victimization. And it's interesting to engage in gender-based violence this way because it is often a difficult construct to measure and capture. So remember this journey that we're on. We're going to make 3 research stops. The first is talking about what is currently known about gender-based violence syndemics, particularly in low and middle income contexts. The second is how can we engage with this theory in a different way to look at maternal child health disparities. And the third is how we can use mixed methods to test syndemic theories in low and middle income countries. So here's our first stop. Where is our field currently with analyzing gender-based violence syndemics? So to answer this question, I conducted a systematic review of all quantitative literature that integrated gender-based violence as part of syndemic theories in low and middle income countries. I sourced about 4,000 studies, reduced that to about 45, And of those 45, I asked 3 questions. How do we integrate gender-based violence? Where are the gaps? And what are the good and promising research practices? So here's what I can tell you. Gender-based violence clusters with a number of different conditions that can be organized into these broad categories. But mainly, most scholars are treating gender-based violence as one epidemic that clusters with others. There are less studies that look at how other parts of context or other conditions lead to the perpetration of gender-based violence. So overall, as a field, we know more about maybe response than we do about prevention syndemically. The most common types of violence that were integrated were intimate partner violence, non-partner sexual violence, childhood sexual abuse, and violence against sex workers. And we can see here the types of conditions that we have evidence for clustering and interaction. So violence clusters and interacts with substance abuse, mental health, social connection and belonging, sexual and reproductive health, and socioeconomic instability. This could be related to stressful life events, armed conflict, hunger, food insecurity, etc. But the most common conditions that were studied were depression, alcohol use, and illicit drug use, relative to constructs related to HIV/AIDS, so risky sexual behaviors and positivity. But we wouldn't be talking about theory if it weren't for testing. So recall that clustering is one of the conditions needed to demonstrate a syndemic. So how is clustering tested empirically? Well, this was actually the most assessed tenant because it's relatively easy to run descriptive statistics on the proportion of a population that has 1, 2, 3, 4 or more syndemic conditions, often represented with a Venn diagram. But there are some promising applications of spatial epidemiology. So where in a particular geography is this clustering occurring, and is it occurring above and beyond chance? The second tenet, if you recall, is interaction. Now, without getting too technical, there are various ways that one could test this notion of interaction, but not all are created equal. Recall that a syndemic is about the amplification of harm. So by nature, we have to test interactions on multiplicative and additive scales, or we might look at path analyses. So how is violence a predictor, a mediator, leading to other types of epidemics and harm down the line? So about 50 to 60% of articles actually engaged with the interaction tenant, I would say in an appropriate way. So long story short, the takeaway here is we need to do a better job at testing interactions. Now, the last tenet of syndemic theory is context or the environment. And this is really at the heart of the theory, because if it weren't for these socioeconomic political disparities or inequities, we would not expect clustering and interaction to happen. So how did we do at testing context? Well, unfortunately, it was the least assessed. And when assessed, geospatial approaches with hotspot analysis and tracking those to historical injustices was a way to get at this tenant, along with picking a context variable, measuring it in the best way possible, and positioning it as the main predictor or as an exogenous variable that is not acted on by anything else in the model. So that's great, but where do we go from here? What does this tell us about our next steps in the field? So number one, we need to estimate the prevalence of syndemic burdens to a greater degree and quality and use the appropriate data sets. We can leverage some promising practices of geospatial hotspot analysis to locate where this clustering is occurring and tie it to maybe some injustices or inequities. And we can look at cross-level interactions, so where a group or context variable is interacting with the individual level. And none of the literature looked at this last point. Empirically, I think we can expand beyond substance use, violence, and AIDS. And I'm really interested in testing intergenerational maternal-child disparities using this type of model. So that's great, because that's the next stop we're making here on our research journey. So I extended the application of Syndemics to intergenerational maternal-child health disparities using publicly available data from the 2022 Nepal Demographic and Health Survey. So here's the syndemic model. So what you're looking at here is the model that I've been developing and testing. So the observable phenomenon, if you will, is at the top of this figure. So we have some sort of disparities happening at the parental unit. I'm focusing here on mothers. And those are somehow transmitted to children. And I argue that one way that this transmission occurs is through a syndemic lens. So we know that typically people are housed in communities and families are situated in some sort of a home environment. And some of those homes are on the lower end of the socioeconomic gradient, and others are on the higher end. And I argue that those homes on the lower end of the socioeconomic gradient face greater clustering and interaction between maternal health disparities. So I focused on intimate partner violence, depression, and inadequate dietary nutrition. So amongst these lower socioeconomic households, we expect a greater burden of clustering and interaction, which then leads to the amplification of child health disparities, of which there could be many. But I focused my investigation on child diarrheal disease because, as many of us know, it is a leading cause of underchild mortality and could lead to later acute and chronic malnutrition in children. So from this visual model, we can actually ask questions about clustering, interaction, and context. We can ask whether intimate partner violence, nutrition, and depression can co-occur amongst Nepalese mothers. We can ask whether the probability of a child disparity outcome like child diarrheal disease is greater when mothers experience this triple burden above and beyond the double or single burdens. And we can also ask whether the magnitude of clustering and interaction is greater or becomes existent when we focus on households that are lower on the socioeconomic status gradient as opposed to higher. So what did we find? Now, being mindful that with all secondary data analysis, we have limitations on what is measured, what is gathered, and what the sample size is. So I created about 2020 maternal child pairs. So that was my sample size. And there was evidence that mothers in the poorest households, so the bottom two quintiles, had a elevated burden of single exposure to these three conditions, but also double exposure to not consuming iron-rich dietary sources and intimate partner violence concurrently. And when I looked at the prevalence of this clustering of the three conditions, it was relatively rare. So about 310 per 100,000 mother-child pairs experienced this particular clustering. But this was globally amongst all households. Amongst the poorest households, the prevalence about doubled. So I wanted to show you the modeling results visually because I think it's most impactful this way. So I ran some interaction models on multiplicative and additive scales, and the three-term clustering of those three maternal conditions was statistically related to higher odds of child diarrhea by about 32% in the model. And this is happening above and beyond a double exposure and above and beyond single exposure. But here, visualized on the slide, we have the model predicted probabilities, and we can see where the synergy is occurring. On the x-axis, we have maternal depression score. I left it as numerical using the PHQ tool. And on the y-axis, we have the probability of child diarrhea, and we have the different groups of mothers exposed to whether or not they consume dietary rich iron sources and whether or not they are exposed to intimate partner violence. And what we can notice is this blue line, which represents the mothers exposed to intimate partner violence and not consuming dietary iron sources. And what we can see is that when mothers emerge into the moderate or severe levels of depression, about a level of 9 and above, the predicted probability of child diarrhea is elevated compared to the other groups. And this is specifically in the two most disadvantaged households. So the two lowest levels of household wealth. A different pattern emerges amongst the less disadvantaged households. So achieving an average level of household wealth and above. We do not see that same patterning in the blue line, although we still notice that likely there's still a harmful effect of maternal depression on the probability of child diarrheal disease. So what did we learn from this analysis? I argue there are two takeaway points important for practice and policy. This intergenerational maternal child syndemic affects a small proportion of Nepalese mothers in the most disadvantaged households. But it yields a synergistic magnification in the probability of diarrhea, and we can use this as a lens to understand how this health disparity might be perpetuated. And this occurred after holding constant water and sanitation infrastructure and other hypothesized confounders of this relationship. So what do we do? What do we recommend? Here is visualized what is called the proportionate universalism approach in public health. So it's universal because all mothers and children in households can probably benefit from some intervention, at least regarding depression, maternal depression. But we need to intervene with a higher proportion, a higher intensity, a higher frequency among those groups that we know have a syndemic vulnerability from this analysis. So those are those households and mothers and children that are in the lower socioeconomic status gradient that we know fare worse in terms of the outcome. So we're really intervening on those particular groups that have this endemic vulnerability to reduce the gradient that we see in health. So we're going from a baseline of pink, which you can see it has a particular slope, there's a particular gradient there, and we're leveling the playing field using proportionate universalism. So I've told you about this model that I've developed and tested, but I didn't tell you why I thought to link violence and nutrition. And it's been a journey because I didn't wake up one day and think to do this. I was engaged in other kind of tangential work, and I want to tell you how I got there. So I was part of a UNICEF-funded project to really look at the interface between gender-based violence and child nutrition. And there's actually a paper published by some of the faculty members in this group, I think it was in social science and medicine, that did somewhat of a review on these pathways. So we took this and we kind of ran with it, extended on this work, and we published two rapid evidence assessments. The first on the indirect pathway, where mothers are exposed to intimate partner violence within their relationship, and the children that they bear face worse in terms of their nutrition outcomes at various stages of development. But there's also a direct pathway where girls themselves are exposed to gender-based violence, for example, intimate partner violence, childhood sexual abuse, or the combination between the two. And they fare worse in terms of nutrition outcomes later on in their childhood trajectory and early adulthood. So this is great, but it tends to focus on child nutrition outcomes. And I argue we know less about how violence impacts women's own nutrition outcomes in adulthood or when they are in reproductive age. So I then asked another question, which was, does past year intimate partner violence reduce the consumption of dietary iron sources, particularly animal sources, heme sources of iron? And again, I went back to the demographic and health surveys. I located all of the surveys that measured both intimate partner violence and minimum dietary diversity. And I crunched some numbers, and I have these results over here. So there's eight countries of analysis, most recent demographic and health survey. And we can see here some forest plots showing the association between past year intimate partner violence, 4 types, and the odds of consuming iron-rich heme sources. So this is your animal products, for instance. And in all cases, the pooled results show that Intimate partner violence exposure reduces the odds of consuming these types of foods after holding constant some known and hypothesized confounders of this relationship, like number of children in a household, polygynous households, household wealth, and so on and so forth, with the most extreme being the sexual intimate partner violence exposure. So I've told you how I arrived at this model. I've told you how I've tested it. We have some interesting preliminary results of the use of this model empirically. And there's more that I want to do with it in the future. But I also want to talk about qualitative methods. How might we take this model and ask follow-up qualitative questions given the results that we have in our initial quantitative investigation? So this brings me to my last stop. Actually, this is one that I'm most excited about because I developed a framework for investigating syndemics using qualitative and quantitative methods. So to develop this framework, I used a three-step approach that's available in the literature, where you review the literature, you synthesize it, and then you refine the framework by asking experts in syndemics to ask them what they think about the model. How may it be refined? What are their opinions on how the model should be used? So I'm a fan of explaining things simply and intuitively with analogy and metaphor. So if you can understand these two pictures, you can understand the framework. So I like to think of quantitative methods, at least in the way that we think about them in syndemic science, as the population perspective illustrated on the top right. So this is like when you're in an airplane and you look out the window and you can see your population of analysis. You can see how homes are organized, how the urban planning is set up, and metaphorically, you can see where clustering occurs, maybe the magnitude of those types of interactions. But what you don't know is what the perspective looks like on the ground. So the qualitative perspective illustrated on the bottom left is what I like to call the locally grounded perspective. This is, for example, when you get off the airplane and you walk alongside members of your target population. You will get to understand colloquialisms that they use when they speak. You will understand the major issues, what they're stressed out about, what they're thinking about. You might notice the materials that the roads are made out of, or the materials that the buildings are made out of. And that is what I argue is context. And remember that context is one of the key elements of syndemic theory that is, generally speaking, not assessed in most of the empirical literature. So when using this framework, there are two central considerations. The first is, which method do you begin with? Do you start up in the air or do you start on the ground? And secondly, why are you mixing methods? Why are you strategically positioning one and then the other? What is the value add in terms of illustrating these syndemic dynamics? And let me give you an example here. So say you're starting off qualitatively, so you're walking alongside members of the target population, and then you take your airplane up and look quantitatively. So I argue that this design is well suited when a syndemic model is unknown or when you're starting one from scratch. So you need to know what you need to measure, how you're going to measure it, what variables are going to enter your interaction term, what does context mean? There are many unknowns that you have to then plug into the syndemic model. And so you start off qualitatively, you develop a causal model that's grounded in the lived realities, social context, political context of the place. You're able to isolate both obvious and non-obvious aspects of context relative to the syndemic and start to define and develop your measurement tools. What about the opposite case? What if you're starting off in the airplane, looking at the target population? You then step down from the airplane and you walk alongside. the target population. Well, I argue that this design is better situated when you have a reason why you're combining variables in a particular way quantitatively. There must be an a priori or conceptual reason why you are integrating variables in such a way, why you're defining context in a certain way. So maybe you're trying to test the substance abuse, violence, and AIDS syndemic, which has been widely studied in a variety of settings in your particular region. But even if you have promising quantitative findings, you don't have the full picture yet. You may have to develop a richer mechanism that explains the quantitative findings further, that might counter the model that you are seeking to develop and explain. And you might want to think about what intervention strategies are contextually appropriate to intervene on the quantitative model that you've developed. So with the culmination of explaining the conceptual model, we're reaching the end here. And I want to end with some summary notes. So we were on this beautiful journey together. We started off by talking about what successes global health has had in the past 50 years and counting. One of them being that child mortality has reduced, although somewhat inequitably. But we also noticed that children face persisting forms of violence from a variety of actors. And we've noted that violence against women and children share many of the same underlying drivers, and we can use the polycrisis as a lens to integrate this complexity. And syndemic theory is one approach to operationalize this complexity, so we actually can do the work of scientific testing, theory development, intervention design, and whatnot. I've told you a bit about the syndemic model that I've developed and tested, as well as a framework for integrating quantitative and qualitative methods to do syndemic science a bit more holistically, let's say. But there's more that I want to accomplish in this space. So this takes me to my culminating slide, which is the future research agenda that I hope to build. So I'd like to introduce you to the Syndemic Science for Health Equity Lab. The mission of this lab will be to analyze and intervene on the pathways through which these fragile socio-political structures interact with violence to magnify population harms. There's going to be 3 ways that we accomplish this mission. The first is curriculum and training. This is where we continue to advance the methods and frameworks of syndemic science involving gender-based violence, but also beyond. And part of this is training the next generation of global health and development actors to think syndemically, to think about context, clustering, and interaction, using both qualitative and quantitative approaches. The second is a global mapping of syndemic vulnerability using publicly available data. So I talked a bit about the importance of using geospatial mapping to identify where clustering is happening, associate a magnitude of harm of that clustering, or ways that syndemic pathways are happening, and make this publicly available. Make a dashboard that all countries and ministers and the public can see about how a construct like violence is leading to more harms in nutrition, is leading to more harms in mental health and child health. And lastly, we need to also focus on pragmatic impact. So there are many stakeholders involved in child's health and women's health internationally. And part of this work will be creating knowledge products that are useful for them. Probably a very prestigious public health journal is useful for us, but maybe less useful for them. So what type of knowledge products do they need to communicate these findings? And what vocabulary and language do we need to adopt to explain the complexity of syndemic thinking to them and guide them in how to act? So there are 3 pillars that support this work. So there's a pillar of methods and capacity building, a pillar of knowledge creation, and a pillar of knowledge translation and dissemination. And I invite faculty members and students here to think about how they might be positioned in this space. So, Catherine Yunt and Carrie Clark, I think are are great to be situated between methods and capacity building and knowledge creation, given that they've done a lot of work in refining measurement approaches to violence, refining, structural equation modeling, and all of that scientific work. But there are others too, like Dabney Evans, who is situated at the intersection of law and global health, and can bring those kinds of stakeholders into the conversation. But I'm mindful that there are many folks here working in maternal child health, nutrition. So I think there are many areas to create synergies, so to speak. Okay, I'm gonna stop talking. I'm gonna invite you to talk as well so we can have a discussion.
Jyoti.
Luisa, thanks for presenting. It was like, I really appreciated like the approach you're taking in terms of like trying to couple context, clustering, and interaction. For your step 2, I do have certain issues with your statistical inference and your causal inference. You have used like cross-sectional data to somehow derive some level of causal associations, given that there are known challenges with like the DHS data, especially regarding unmeasured confounding. So that's a causal aspect of it. And like you're calling these interactions, which may in fact just be effect modifications, which are uncontrolled. So that's the first one. The second one is in terms of statistical inference, which is when you're using DHS, the sample size is roughly like about 12,000 for Nepal. Your prevalence of your exposure variable, which is like the triple burden, was 310 out of 100,000. So your entire inference is based on 31 people. After adjusting for covariates, your power would be substantially lower. So just want to hear about that. And the other things being regarding multiple testing. So you had like shown a lot of like estimates, but a lot of them are interaction effects. So did you assess things like RERIs, or did you account for just p-value corrections? Yeah, thank you.
I'm ready for you. So lots of things there. Interaction is a very difficult and complex statistical beast to wrap our heads around. So you're exactly right. I'm using DHS data. It is cross-sectional. I don't actually think that these are causal associations or causal mechanisms. I think there's more science we need to do to fully understand them and measure them at the right temporal sequence. So for example, intimate partner violence was in the past year. Then we have the mental health depression measure, which was past month. Dietary intake was past 24 hours, and child diarrheal disease is past 2 weeks. So already in the temporal sequencing of the variables, we don't have necessarily the correct causal structure. So I agree with you there, but I think it's at least preliminary evidence to continue testing this model further and to provide a justification of why we're going back in the field and asking people to answer another survey, right? I think there's saturation sometimes in global health. So my approach is to first use the best publicly available data that we have at the time, and then ask deeper follow-up questions to get closer at the causal structure that you are alluding to. Now, the conversation between effect modification and statistical inference. So I actually tested what's called additive interactions, because those are hypothesized or thought to be most informative for public health knowledge. So what that means is the combined probability of child diarrhea greater when we have the interaction term that contains a 3-term interaction, each 2-term interaction, and each single-term interaction. So the model actually has 7 variables. It's a fully saturated interaction model. And I tested on a multiplicative scale, so the logistic regression, but I also tested on additive scale. So you can calculate the relative excess risk of interaction, or the AP, or the synergy index, which I did calculate, and they were significant. But I think a better way to test it is to run an albeit imperfect model on a linear scale. So take your binary outcome, run it on a linear scale, and as a sensitivity analysis, see if that interaction term is still significant. So the estimates that I presented to you were both on a multiplicative scale and an additive scale. And the model predicted probabilities, I think, are additive in their nature, right? You can see and calculate what the predicted probability is of child diarrhea at these different intersections of maternal comorbidities, if you will. But I actually had two binary terms, so violence and consuming a diet rich in iron sources, but I left the PHQ on its linear scale. Because you're right, the prevalence of all three binary, moderate severe depression and intimate partner violence and iron was quite low. So recognizing that, I left it as continuous to give a bit more statistical power in that domain. So here's your logistic regression model, but essentially here we're looking at the way that the outcome is transformed to get a linear function of the probabilities makes this a multiplicative scale. So you can't assess additive interactions on this scale, which is why I looked at the linear probability model and calculated the RERI. But here's the model. So you have a 3-term interaction, beta 7, each second order interaction, beta 4, 5, 6, and each single term interaction. And when you I guess interpret beta 7, it's interpreted according to this ratio. So the odds ratio of all three conditions relative to each second double order combination. And here we have the linear probability model, again, a bit imperfect in terms of modeling the outcome, but we can use it as a sensitivity analysis to understand the additive scale. So we have the same model, the outcome is different, there's no transformation, and beta 7 is now interpreted on the linear scale. So the presence of all three minus the presence of double and single exposures. So I trust that answers your question. And the sample size, yeah, so when testing 3-term interactions, you're right, the sample size has to be sufficiently large enough. I ran some power analyses to sort of gauge where I was, and I was entering the analysis already knowing that it was slightly underpowered. But again, let's not let the perfect be the enemy of the good. This is the only publicly available data set that I found that had these particular constructs of interest. And I was actually waiting for it to come out for a long time because it wasn't actually released until last summer. Yeah.
Lisa, I really hope that I get some equations in the answer, because if Jen gets equations, I want equations. That was nice.
You've done other interactions.
Yeah. I want to make a quick comment, and then people are going to classes and stuff. I want to make a quick comment, and then a question, and I know we're kind of getting at time. The comment is, I think you actually make a really persuasive case for us to give up this old-fashioned way of thinking about the relationship between qualitative and quantitative work. I think we should flip the relationship. I think quantitative is exploratory and qualitative gets us closer to something that looks explanatory. We can talk about that later. It's just a comment. The question is, through the whole presentation, and we had a bit of discussion earlier, see all kinds of really interesting threads in terms of how we might think about development. And it actually brought to mind for me a lot of it, Amartya Sen's Development as Freedom, which is a really kind of, it's very influential in my own thinking. I just wonder if you could maybe give us a few thoughts about how you see the relationship between, this work or global health in general and development.
Yeah, that's a large question, but I know that it's
I want
central.
equations.
Yeah, no, unfortunately, no equations work there, and I know it's central to the thinking in this department in the future. I think it's very difficult to talk about mounting a public health response in absence of institutions that are trusted, that are adequately funded, and that are transparent. And that actually links to a bit of what I'm doing in my postdoc work. We've already talked about this, but I'm interested in taking a critical look at fragility. So if fragility is to be maintained as a useful concept in global health, I think we need to imagine it and critically engage with it a little bit more deeply. It's thought to be associated with conflict settings. Those are the types of obvious fragility that we can recognize. I think that there are types of fragility that impact global health that are not conflict-affected countries. And I'm thinking about the ideologies that inform the way that institutions operate, run, and are funded, and who they really serve. So in one of the conceptual pieces that I'm currently writing as part of my postdoc, I imagine fragility actually as a process when resilience breaks down. So when a country or a region is faced with a threat, an external threat, let's say, it has the ability to respond in ways that ameliorate harms on aggregate. So on average, measures of central tendency, we can reduce those harms while also improving equity. Sometimes you can reduce harms on aggregate, but you don't necessarily address the equity gaps, or sometimes that they're made worse. So if resilience is ameliorating harms and promoting equity, fragility happens when that process breaks down. And I've been thinking a lot about, well, what happens to institutions in that they're unable to promote resilience in times of threat? And I think that there are two considerations. One is that a governance structure chooses not to act, either because it is ideologically opposed to acting, or it might like to act, but it doesn't have the capacity and wherewithal to act. So already there's a failure to act because of two main reasons. Now, if a country decides to act, so it's ideologically aligned and might have the capacity to do so, there may be implementation challenges. So it actually can't implement a strategy or an intervention because maybe the evidence isn't quite there yet for that type of intervention. Or maybe there's an authority issue where that governance structure can't get people to essentially do the core business of implementation science, which is to change and alter behavior and add them into routine practice. Or there could be a legitimacy gap where people don't trust that institution and are not going to follow what they say. So I think that that is tied into development. And I really don't think that you can have a sustainable public health response without a functioning institution. And I think part of that is fragility, and we want to get to resilience, but oftentimes we fall into fragility. And it doesn't matter if it's a high income country or a low income country. The process is similar.
Thank you.
I think we're out of time, but if I have 30 seconds, just.
Yeah, no, go for it, Catherine.
Just a comment, and because I have more questions than are appropriate for right now, and I'd love to follow up with you. I wanted to take a moment and just applaud your boldness in theory, your ability to articulate complex theory in a very tractable way for public health, and then showing extremely tractable ways of addressing those research questions in integrative and person-centered methodological ways. Really wonderful presentation. So I just wanted to say thank you.
Catherine and I, we wrote that paper only 20 years ago, right? Yes, and then get proposals funded.
That's right. It comes out of a proposal that addressed what you're
We
addressing.
didn't get the money to do the work, but.
But we got a good, really great.
Gosh,
Yes.
you know.
Hire the next,
No, but I want to just add, great job. I guess I want to put my intervention hat and
Yeah.
ask the question that as we think of, okay, we know things quote unquote cluster, whether they're, Ari's not here because we did something.
He's online.
He's online. You know, when we talk about co-occurrence of conditions, if it's high enough, just mathematically.
Yeah.
The co-occurrence goes up. Does that mean it's just that, yeah, it's by chance versus the good old chi-square test, right? But irrespective of whether they're causal or whatever, the question is, when resources are limited, what do you do where, and what all do you do where?
Yeah.
And so just wanting to think, how would you take this to evaluate integrated intervention strategies? So in the little field of nutrition, that's why I went to multiple micronutrients, because I said it'll take several lifetimes if we're going to figure one nutrient at a time. So I don't get me to just throw everything. Some may not be needed, etc. But we know time and again, at least in the maternal child health world, when we even do different interventions, the wash area or nutrition, it just doesn't move the needle enough. And so as we think of, where do we have integrated packages? How do you integrate them? And then how do you evaluate them? And how will this approach help in the evaluation? Did you see what I mean? I know it sounds very broad,
Yes.
but these are the real challenges, right? Because in many places, people are saying, I'll do A. Because I'm doing A, I don't have money to do B and C, where there are those of us, well, you need to do A, B, and C. So just wanting to get your thoughts
Yeah,
on
thank you.
moving to the intervention part.
Yeah,
Yeah.
thank you. Yeah, I understand your question. Relating back to the causal question, if we could analyze this causally, what syndemic theory is actually telling us is that if beta 7 is having a causal impact on the probability, you could intervene either on IPV, depression, or dietary iron consumption to disrupt the synergy if it was a causal additive interaction, as this model proposes. So as our methods and our research design get closer and closer and closer to the ultimate goal that is causality, even if we're not there yet now, we can think about how to design interventions. So one area that I've been thinking about and grappling with is, in some contexts, we may know that intimate partner violence is a factor that results in harm, but it's not appropriate for us to intervene on intimate partner violence. The context may not be ready for that. It might not be appropriate. It may create other types of harm for women and children. And so under syndemic thinking, maybe we can intervene on the depression or the iron and use that as an in to do more gender transformative work. So with that in mind, you can design an intervention depending on the context. Maybe in one context, you start with the violence, see how that goes, assess implementation outcomes. In another context, start with depression, see how that goes, assess intervention and implementation outcomes. And then try with the nutrition outcomes. Because I'm mindful that although we may want to intervene on violence and get at its determinants and its preventative factors, it might not be realistic in any given setting. So I agree causality is important, but even before we're there, we can start to think about what is the power and the value add of syndemic thinking and design sort of hybrid implementation trials that assess the value add of starting with X1 or X2 or X3 in different kinds of combinations, and then maybe see which one is effective and lowers cost.
I think that's a beautiful description of how the quantitative analyses are exploratory and provide a lens for deeper, as you said so elegantly, and just, define a lens for deeper qualitative investigation that can start getting at some of those causal mechanisms more explicitly, the more explanatory piece. I'm going to keep this crusade till I retire or get fired. It's not for hypothesis generating.
I would turn it on its head and say, this calls for, even when you're doing
Formative
clinical
development.
trials, etc., it's not a simple randomized trial. You need trial design, and this is coming from my work where we've done with DHA, and we find that genetic polymorphisms modify, and we found that after the fact. So the thing is, when you have enough information, you do layered intervention.
But we
That's
still
what-
believe
that's what I'm
the
getting.
trials are going to provide explanation, and they don't. The
No, they
trials-
don't have to provide explanation. They'll tell you whether it's worth doing it. Is it
do
worth
they-
doing the
What's the
intervention?
external validity? Like, I think.
This is a long
It
conversation.
is, but I think we're, yeah. This is
This
really
is-
fun.
Is
But I
it worth
couldn't get
giving iron
information.
supplement to depressed women who are experiencing violence? That's the question.
Yeah.
I'm putting.
One quick, this is such an exciting conversation, very rich discussion. One quick comment though, and tipping a very respectful hat at the limitations of quantitative data analysis. And that really has to do with the quality of the measures that you're putting into the model. And I have lots of questions about the performance of the PHQ in certain contexts, lots of questions about how we measure. I just looked up 27% of women reporting lifetime IPV. I don't believe that. I think it's double. So what happens when you have substantial misclassification and you're building your ideas around integrative, and you've got disproportionate mismeasurement of one variable over another. So I think you explained this again elegantly, taking a complex model. I think there's a strong push for mixed methods measure development that we have not given full shrift to, and we have this massive machinery at the DHS which could actually be misinforming us about the magnitude of these syndemics.
Yeah.
So just a note of caution on the measurement side.
Yeah, no, I completely agree. I don't think that there's a gold standard to measure a construct like violence.
No.
We're not there yet.
No, but we're way off.
And even the page Q, there's an adapted version for Nepal, but the DHS doesn't include that one. So yeah, we have some misclassification error and potential bias as well, yeah.
Well, listen, thank you everyone for your spirited participation. Louisa, thank you for a lovely presentation. Really, really appreciate it.